cancer control is a huge topic, knowing that we have a tsunami of cancer coming with increased life expectancy, aging of the population growth, and just simply the fact that we can do much more about cancer right now. The long-term survival in cancer patients has doubled over the last 40 years. So most people survive. Most treatments are much more effective, so patients can have more than one lines of treatment, and the cost of cancer care and the complexity of cancer care is growing. So we know that there are huge gaps in access to cancer services, both to diagnostic services, to prevention services, as well as to treatment. And we also know that cancer is a team sport. It requires engagement of all the diagnostic services and all the treatment modalities. Very few patients are treated with just one treatment modality. And yet when we plan for cancer control and when we do gap analysis, we only look at one treatment modality or access to try to solve one problem. We need to work together. There is certainly a need to do a piece of work to look at the gaps in access to specific treatment modalities. There's been a lot of work on access to cancer medication, cancer drug. There was Lancet Commission on access to surgery, and specifically then cancer surgery, and the problems that result from lack of access to this treatment. While I was president of UICC, we did a huge piece of work on access to radiotherapy globally, and we actually priced how much money would it cost to scale up access so that anybody in the world who needed radiotherapy would receive it in a timely manner. We then calculated what would be the benefit of such scale-up. But we made a lot of assumptions. We made assumptions that patients have access to timely diagnostic services. We made assumptions that they have access to surgery and chemotherapy in order to benefit also from radiotherapy. And I think at some point in time, we must work together and look at the gaps in on-cancer modalities and how we scale up access to appropriate cancer treatment that is multidisciplinary. So the surgery, medical oncology and radiation and supportive care people really need to start working together to make sure that we make progress. So for the patient, the differences between different disciplines are not seen. They're blinded. The patient wants just their cancer cured and want to benefit from treatment, and the challenge is for us to start working together more. I think just as we need to work together between the disciplines, we need to work together between the organizations. I understand that every organization wants to be the best and have the biggest possible impact, but the fact is we can't do it alone. So we need more of the global collaboration, global cooperation. And in order to cooperate, everybody has to be able to give up a little bit of their own turf in order to make better progress globally.